Welcome to The Explainer. Today, we're taking a clinical walkthrough into the complex world of diagnosing and treating co-occurring disorders. Typically in clinical training, small groups will huddle up, review assessment results, and figure out the exact level of care for a shared case. They'll often review up to 3 different clinical vignettes and really dig into a treatment plan template. Well, today, we're going to do exactly that together. We're going to review assessment results, determine levels of care, and map out integrated treatment plans.
Okay, let's dive into this clinical masterclass journey. We'll be moving from abstract theory down to highly specialized treatment planning. We're going to start by defining addictive behaviors and tackling the co-occurring challenge. Then we'll move right into assessing levels of care and looking at some real-world clinical vignettes. Finally, we'll wrap up with integrated treatment planning and how to effectively engage patients using motivational interviewing.
So, first things first, let's talk about defining addictive behaviors and the current debate surrounding the ICD-11. Because before we can even begin to treat a co-occurring disorder, we have to know exactly what we're treating, right? Which brings up a fascinating question that researchers are actively debating right now. Where exactly do we draw the line between a bad habit and a true disorder? I mean, we all know about substance use, but what about behaviors? Think about shopping, excessive social media use, or gaming. As the ICD-11 introduces new categories for things like gaming disorder, we have to be incredibly careful. We absolutely cannot over-pathologize everyday life, but we still need to make sure we're treating legitimate clinical impairments. To solve this, researchers have actually suggested 3 very strict criteria to determine if a behavior truly qualifies as an addiction. First up is clinical relevance. Basically, is there an actual undeniable functional impairment in the patient's daily life? Second is theoretical embedding. Does this behavior naturally fit into our established neuroscientific models of addiction? And third, empirical evidence. Do we have the hard data showing that the underlying neurobiological and psychological mechanisms are exactly the same as other recognized addictions? It's like a highly exclusive club. If a behavior doesn't hit all 3 of these marks, it simply doesn't get the label.
That takes us from single behavioral addictions into the deep end, the incredibly complex reality of co-occurring disorders, or CODs. Treating CODs is a massive challenge, so Sam Hepsi uses the 4 quadrants of care model to give us a really clean, simple mental grid. You basically place the patient on this grid based entirely on their symptom severity. So, a patient with a less severe mental disorder but a severe substance use disorder, they fall into category 3. But a patient with severe presentations for both, they land in category 4. It's a fantastic tool because it instantly gives you a high-level view of the exact resources and intensity of care that a specific patient is going to require.
Now, what's really interesting about this assessment process is how we actually gather that data during a clinical intake. SAMHSA outlines an intake process that honestly can look a little overwhelming at first glance, but it really just breaks down into 3 critical milestones. Step 1, and this is absolutely crucial, is always safety screening. We literally must check for imminent danger, suicidal ideation, or risk of harm before anything else. You have to establish safety. Step 2 is determining the level of care, and Step 3 is to actually build the treatment plan, matching targeted interventions to the specific needs we've just uncovered.
For that second step, determining the level of care, we rely heavily on a tool called LOCUS. That stands for the Level of Care Utilization System. It is a highly standardized clinical tool that evaluates a client's individual needs across 6 different dimensions. Using LOCUS is a real game changer because it allows a clinician to definitively say, okay, this patient needs flexible, community-based services versus, no, this patient requires immediate inpatient hospitalization. It totally removes the guesswork.
So let's take a seat in the clinician's chair and actually apply this framework to a real-world clinical vignette. Meet our shared case for today, Teresa G. She's 37 years old and was just admitted to detox with a staggering 0.21 blood alcohol level. Clinically, she presents as very withdrawn, she has poor concentration, and she admits to having fleeting suicidal thoughts. We also know from her file that she has a history of 3 prior hospitalizations for depression. But here is the critical, really complex detail we need to navigate. Despite her physical presentation, Teresa is currently denying that she feels depressed at all. She actually states she is, quote, just fine. When we map out Teresa's co-occurring presentation, the reality of her situation becomes crystal clear. On the substance use side, we've got the extremely high BAC and the recent severe alcohol-related problems. On the mental health side, regardless of her current denials, her presentation, being withdrawn, the suicidal thoughts, and that well-documented history of major depressive disorder tells a completely different story. So applying our 4-quadrant model, Teresa perfectly fits into the most severe categories.
She's going to need interventions that address both a severe substance use disorder and a severe mental health presentation simultaneously.
Now that we've properly assessed her level of care, it's time to build a comprehensive roadmap for her recovery. And this brilliantly illustrates what that looks like in practice. SAMHSA's treatment plan template recommends 10 essential program components for treating co-occurring disorders. Notice just how comprehensive this whole shebang is. We're not just talking about basic once-a-week therapy. A true integrated COD program includes things like an on-site prescribing psychiatrist, targeted psychoeducational classes, and dual recovery mutual help groups. For a patient like Teresa, integrated treatment means her substance detox and her psychiatric evaluation for antidepressants are happening right there, under one unified, collaborative umbrella. But here is the hard truth. All of this brilliant clinical theory completely falls apart if we can't effectively talk to the human being sitting in front of us.
Let's look at how to actually have this conversation, using a vignette from our source texts. Notice how the clinician starts out here. They don't walk in and say, "You're an alcoholic." They say, "Your gamma GT is 220, a normal value would be 66. They just explain the science, that this level rises when one drinks more alcohol than the liver can break down over a long period of time. And then they ask the vital question, how does that sound to you? It's an entirely objective, non-judgmental presentation of raw data. The whole goal is to avoid triggering the patient's defensiveness.
And yet, as you'd probably expect, we still get some resistance. The patient responds, "I really can't imagine that. I don't actually drink that much." But then they give an inch. "Well, okay, sometimes when I'm under a lot of stress, I'll have a few more beers in the evening than usual." This is totally natural. The patient is minimizing their behavior. The absolute key to motivational interviewing is that the clinician doesn't attack this minimization. They don't argue. Instead, they use empathy to keep the conversation moving forward.
Look at this masterful response from the clinician. So this surprises you? On the whole, you've got your drinking well under control. You only really drink a bit more when you're under a lot of stress. You see what they did there? The clinician is just rolling with the resistance. They're actively validating the patient's stated feelings so the patient feels heard and, more importantly, safe. By reframing the patient's own words, the clinician actually empowers them to start exploring their own behavior rather than forcing them to build up a defensive wall. Let's move to and see how this builds into real clinical outcomes. If you're wondering if this soft skills approach actually works, the empirical evidence says yes, absolutely. Motivational interviewing yields massive clinical success. Look at the data here. This conversational style drastically improves odds ratios across multiple health metrics. It's incredibly effective for reducing the amount of cannabis and alcohol used, and it significantly boosts the patient's overall readiness for change. Empathy isn't just a nice, fluffy idea, it's a scientifically validated clinical tool. Which leaves us with this final provocative thought. As our diagnostic frameworks like the ICD-11 and assessment tools like Locus continue to evolve and become hyper-precise, how will our human empathy keep pace with our clinical precision? We can build the absolute perfect, most integrated treatment plan in the world, but at the end of the day, it's the deeply human art of listening, validating, and connecting with patients like Teresa that actually saves lives. Thank you so much for joining me on this explainer. Keep learning, keep listening, and I'll catch you next time.